Thank you, sir. Vitreoretinal causes or vitreoretinal indications for ultrasound probably from the most important reason why we are doing ultrasound. There are a whole lot of things which can be studied on a B scan. This includes right from your vitreous, the retina, the choroid, the optic nerves in trauma cases and tumors and other than that. We'll start with one of the most common indications as to why we do an ultrasound, and probably the most common indication is a patient presenting with vitreous hemorrhage. Now when we do any particular test, we do it for a reason. It's not just that vitreous hemorrhage is there, you want to do an ultrasound. You need to know why you're doing the ultrasound, what information you're likely to get from the ultrasound, and how is it going to help you manage your patients better. So in patients with vitreous hemorrhage, what you're looking from in an ultrasound test is, what is the type of vitreous hemorrhage? We'll be seeing this in subsequent slides. What is the PVD status? This is extremely crucial for us for a number of reasons. What is the status of retina? Obviously, this is the most important reason why we are doing the ultrasound, because if there's a retinal detachment, your management becomes surgical, management becomes immediate. And can you find a possible cause for the vitreous of vitreous hemorrhage in the ultrasound? If you're able to do this, fantastic. Some cases you're able to do it, some cases you're not able to do this. Very fresh vitreous hemorrhage, extremely easy to miss. The patient comes with a sudden drop in the vision, send for ultrasound, you do the ultrasound and you find almost a clear cavity. And fresh hemorrhage, 1 or 2 days old hemorrhages are very, very low refractive dot-like echoes, very easy to miss. You need to do your ultrasound in very high gain settings. If the other eye is normal, very important to try to compare it to the other eye. That gives you some idea about it. So fresh hemorrhage, be very careful in your ultrasound. You may report it as normal if you don't increase your gain settings, and you may miss those very, very fine spikes that you see on the scan on the ultrasound. As the vitreous hemorrhage becomes older, it sort of clumps, it forms a little more moderate to high reflective echoes. Sometimes it settles down depending on the position in which you're doing the ultrasound. Retrohyaloid hemorrhage, what we mean by that is you have a PVD and the blood is restricted behind the membrane. So you always have a membrane in front with a clear intragel space, and you have a lot of dot-like echoes. Retrohyaloid bleed never clots, so you don't see clumps of echoes. Sometimes it may form a layer on the lower part, and that is called as a posterior hyphema, may be mistaken for a retinal detachment. Again, important from the management point of view, surgically you know where the blood is, it's easier to manage that way. Pre-retinal hemorrhage, we usually don't do an ultrasound, but it may just be seen as a surface irregularity on the retinal surface itself. Is it possible to find the cause for a vitreous hemorrhage? In some cases, yes, and it's important, especially in an elderly patient presenting with vitreous hemorrhage, always look at, and if you have a posterior vitreous detachment, always look at the anterior extent of the detachment where it gets attached to the retina. You may see a sort of a flap-like thing. This indicates most of the time the retinal tear. So you know these are something you can't ignore. This has to be taken up early. So retinal tears can be picked up if looked for carefully. If you're just doing a posterior pole, not looking at the periphery carefully, you may miss a retinal break. Diabetic patients with TRD posteriorly, you know that traction again is a cause for a vitreous hemorrhage. BRVO is a presumptive diagnosis. Some patients who present with a vitreous hemorrhage long-standing, you see attachment of the vitreous in one particular sector, suppose superotemporal or inferior-temporal. Usually most of the patients with a vein occlusion, and if they have a PVD, the PVD remains, the vitreous still tends to remain attached in the ischemic area. So you can conclude to sometimes. Posterior PCVs, or polypoidal choroidal vasculopathy, sometimes bleed massively, and they have a very typical ultrasound picture. You will have a subretinal bleed at the posterior pole. You will have a breakthrough hemorrhage from that subretinal bleed into the vitreous cavity. When you see that kind of a picture, you know you're dealing with a macular pathology there. Important to diagnose this because prognostically very, very important. You have to give the patient a very, very guarded prognosis here because you're dealing with a possible macular lesion here. So in this way, to some extent, ultrasound can help you to try to find a cause. Obviously, other obvious causes like tumors and all, which the subsequent speakers will be speaking on, will be picked up on ultrasound. Some of the tumors can present with vitreous hemorrhage, so that also can be picked up on an ultrasound. Other common vitreous echoes is what we call as asteroid hyalosis, very easy to diagnose on the ultrasound. They have multiple dot-like, moderate to high reflective echoes, and a very pathognomonic, a very characteristic feature, clear space between the echoes and the retinal surface. This is because most of these patients don't have a PVD, and that's the clear cortex that separates out these soap-like deposits in the gel from the retina. Again, ultrasound very useful to differentiate PVDs, retinal detachments, choroidal detachments. If you talk about PVD or posterior vitreous detachment, you can have a complete posterior vitreous detachment where it is completely separated from the posterior retina, attached only to the oral base, or you can have incomplete PVD where you will still have some points of attachment to the posterior to the retinal surface. Points of differentiating are important to again differentiate between a posterior vitreous detachment and a retinal detachment. Number of points you need to take, and you have to be this can vary from case to case. Reflectivity is a good indicator. A low reflective membrane which with good after movements or good mobility is usually indicative of a posterior vitreous detachment. There are other clues which you can use. The points of attachment. If you have a membrane which is not attached to the disc but attached somewhere else, off this, or to the nasal retina, or to the some other point apart from the disc, then you know it can't be a retinal detachment. It has to be a posterior vitreous detachment. Or if you have a membrane which again has a multiple point of attachment as shown here, then this has to be a posterior vitreous detachment. It cannot be a retinal surface. Again, this demonstrates the after movement. By after movement, we mean that you do the ultrasound, you see the posterior detached vitreous, ask the patient to move the eye, and actually see the movement of the posterior hyaloid. Extremely useful indicator to differentiate the two. You have to be very careful in diabetics, because in a diabetic patient, even a posterior vitreous detachment can be high reflective, and this is because of the blood lining of the membrane. So you can get high reflective membranes. Here again, you have to use other clues, like in this case you have a pretty high reflective membrane here, but if you carefully look at the base here, you see a small tenting here. Now when you know this, you see this, you know this has to be the retina here. So if this is the retina, you know this is a PVD. So these are some of the smaller indications which you use, smaller signs which you use to try to differentiate between a posterior vitreous detachment and a retinal detachment. A retinal detachment, when it is fresh, will have a uniform high reflective echo both at the near the disc and at the attachment here. Usually conforms to the shape of the globe, depends on the characteristic of a detachment. As it grows older, it becomes, as PVR sets in, we get what we call on ultrasound, what we call as a funnel shaped detachment. And more chronic detachments, more long standing detachment, you get a close funnel detachment. These are subretinal gliotic bands, what you're seeing. You can see cysts. This can be either because of the folds of the retina or actual retinoceles or retinal cysts, which are characteristic of a long-standing detachment. Important to pick this up because these are almost inoperable cases. You won't be attempting surgeries in these kind of cases. You can have a combination of everything. You can have a posterior vitreous detachment, you can have a retinal detachment, you can have a shallow choroidal detachment in periphery. Almost all cases of retinal detachment, always look at the peripheral area. You may get a choroidal detachment. It's important surgically because your surgical steps alter when you take up these patients for surgery. Very, very long-standing detachments is some presentation. Some of the cases, the detachment can actually be present as an echolucent sort of a band right in the center, which attaches to the disc, goes anteriorly towards the lens. This is said to be various because of atrophic changes and because of the contrast between the dense subretinal echoes which develop in long-standing detachments. Combined retinal detachment is a combination of a tractional detachment along with a sort of a bullous area where we call it a combined retinal detachment. Exudative detachment, you can pick it up in ultrasound by asking to patient doing the ultrasound once in the lying down position and asking the patient to sit up, where you can see the lower part has become more bullous and the upper part is flattened out. So this is how you can pick up a patient with exudative detachment. Giant retinal tears, difficult to pick up sometimes, but anytime if you see a very unusual configuration of a membrane like echo at the posterior pole, think about a giant retinal detachment in these patients. Choroidal detachments, again, easy to pick up and important to pick up on ultrasound. Yeah, they are dome-shaped elevations, almost never reaches the optic nerve head. You always have this kind of a detachment. Sometimes you see a band stretching across in those suprachoroidal space. This is believed to be the vertex veins which are stretched out. And one way of diagnosing choroidal detachment is to do the ultrasound, keep the probe extremely anterior, take a transverse section through anteriorly. You see this kind of a scalloped appearance here. As you see in one of the slides. And again, important to look at the suprachoroidal space in choroidal detachment. Is it clear or does it have echoes? If the suprachoroidal space is clear, then you know it's a serous-retal detachment. If you have a lot of echoes in the suprachoroidal space, you know you're dealing with a hemorrhagic choroidal detachment. In hemorrhagic choroidal detachments, again, ultrasound forms a very important tool for deciding the timing of intervention, because you can find out the exact characteristic of a suprachoroidal fluid. As it liquefies, you can see the suprachoroidal spaces getting clearer, so you can time your retinal surgery or drainage of the suprachoroidal space based on what you see on the ultrasound. Diabetic retinopathy, this will be a repetition of most of what we said. We see PVDs, we see multiple points of attachment in most cases of diabetic retinopathy cases. You can see tractional detachments posteriorly, you can see splitting of the vitreous cortex, we call that vitreous schisis. Look at the periphery also, most of these cases will have a peripheral TRDs in these cases. And the endophthalmitis, you see a bunch of echoes in the vitreous, very difficult to, there has been one or two studies trying to find out, correlate to this etiologically, but really you can't really say this is what kind of a endophthalmitis. You see a lot of echoes in the vitreous. More important in endophthalmitis is to know the retinal status and the choroidal status, because that's what determines the intervention. If you have a choroidal detachment, you have a retinal detachment, you know these are not going to do well. So that's how it helps in endophthalmitis cases. Other cases like colobomas are quite easily picked up on the ultrasound. You see outpouching of the globe. And this is very easily picked up on the ultrasounds. Posterior staphylomas are easily picked up on ultrasound. Optic nerve head drusen, probably the ultrasound is one of the best tests for a patient with optic nerve head drusen. Important to do the ultrasound at very high normal settings and at very, very low settings, and you can see the high reflective echoes at the optic nerve head. And this is very, very diagnostic. You don't need to work this up patients quite well. There have been a lot of cases who undergo all neurologic investigations, and then finally you do an ultrasound where you see an optic nerve drusen. So doing this initially saves you a lot of troubles. You can have dislocated lenses easily picked up, dislocated IOLs very easily picked up. Thysis bulbi, again, totally shrunken eye. Plaque-like calcification in the ocular coats. PHPVs, you need to do the ultrasound in very high gain settings. You can see a membrane stretching right from the disc anteriorly. Patients with ROP, ultrasound has some role in determining your surgical steps, because whether surgery is feasible or not feasible, and especially tells you a lot about the anterior loops here and whether the posterior funnel is closed or open, because that is prognostically important as far as results are concerned. Coats disease and skip. Silicon filled eyes, you really can't do an ultrasound, you don't get much useful information in the silicon filled eye. Post silicon removal eye, most of the patients will have some dot like echoes. These are nothing but residual silicon oil bubbles, usually doesn't interfere with vision. Glaucomatous cupping can be picked up, so when you're doing it in a total cataract patient, always look at the optic nerve head. Is there an excavation at the optic nerve head? If you have that, you know the prognostically you have to be careful here. And non-ophthalmic eyes has certain features, and this can be picked up quite well. You need to do a couple of measurements here, and that's how you pick up non-ophthalmic, useful in diagnosis of non-ophthalmos. I think that's it. Thank you.